Hi, I'm Dr. Michael Miyasaki, and it's great to be here with you again. I just wanted to share a case that isn't too common, but it happens, and it's kind of hard for us to figure out what should I do. So I wanted to go through a case, talk about my thoughts as I did this case. I want to show you the materials that I used as I did this case, and then some thoughts when I got done with everything. So this patient came in last week, and you can see there's this large porcelain fracture off of the PFM crown, which was an abutment to a much longer bridge. And the patient's concern was, what do we do now? Do we have to replace the bridge? Do I have a way of doing some magic? You know, she calls it the Miyasaki MacGyver moves. And I said, you know what? Let's see what we can do. So that's what I want to do is I want to show you where we started on the photo on the left-hand side, and about a half hour later, we were what you see on the right-hand side. And I hope you get the information, because this case, when you understand kind of the chemistry behind it, you can do a lot of things in your practice for your patients. And I think it's a good thing that we can do. So the patient's chief complaint was a fractured porcelain off of the crown on tooth number 6, or the 1-3. This was a long span bridge, which you see here on the bottom left photo, the radiograph. So we have two pontics in the middle, one molar in the back, and then this cuspid. So it was a really long span bridge. Number 3, tooth number 3, or the 1-6, was questionable when you look at the roots, but there's no mobility, no pain, and the patient has a lower partial denture. And that's why I think when this bridge was fabricated, probably decades ago, it was thought that this would be a good way of replacing these teeth, because implants at the time weren't as predictable, and we have a lower partial, so doing a longer span bridge, fixed bridge on the upper right hand side may not be such a bad thing. And then what you can see is there's an attachment between tooth number 6, the cuspid, and the first bicuspid, tooth number 5, or the 1-4. The patient's in her 80s. She reports no discomfort in this area on the upper right. She'd like to try to keep tooth number 6, or the 1-3, understanding that the long-term prospect for this bridge is not favorable, but again, no mobility, no discomfort. And she had to go to a dinner in about 2 hours. So we were seeing her later in the afternoon, and she had a dinner to go to, and she wanted to be able to enjoy her food. So we were working within those parameters. So this patient, when you look at the case, I was thinking, okay, I don't want to replace the bridge. I mean, why would I want to replace the bridge? Because the first molar abutment's very questionable. And so I thought, okay, can we repair this? Now, when I look at the repair, we've got porcelain, we've got metal, and we have tooth structure that we would have to bond this repair to. So we have a lot of different substrates that we have to work with. So we decided, again, talking to our patients about best case scenarios, we decided we would try to repair this crown first, and then if anything happened to it and it didn't have longevity, we could always do something a little bit more, a larger job. We could maybe recrown this with a new crown and take the pontics out and take out the molar. So we decided to go with this, and the methodology is what I want to discuss with you. Now, I put some little dimples into the metal. Sometimes I'll place more sharper undercuts into the metal, but I'm trying to just put some kind of retention into that metal surface. Now, once we get the retention, kind of you see it looks dimpled in this case, I decided to use air abrasion. So I'm using air abrasion with 27 micron aluminum oxide particles to roughen up not only the porcelain, but the metal. And when I roughen up the metal, I take that shine off. So just aesthetically, it's going to be easier, I believe, to hide that silver color of the metal. As we go up in this area, we had sclerotic dentin. So where you see that exposed root surface up there, I scraped it, I drilled on it, and it was actually hard tooth structure. So it's more sclerotic dentin up there than decay. So I went up even in that area and used the air abrasion, because the air abrasion can roughen that up, create micromechanical retention even in the tooth structure. But you just have to be careful. Luckily, this patient's soft tissue is in good shape, but as you take the air abrasion up there, many times that air abrasive particles will irritate the gum, and you'll get a little bit of light bleeding. In this case, if I get a little light bleed in that area, I just take my clear Hemostatic agent, my Quick Stat Free, and I just place it up in that area, rinse it off, and that usually takes care of the little light bleeding that may be caused by that abrasive particles being sprayed up in that area. Sometimes I will just use kind of shield and instrument to retract the gingiva and then protect it as I'm doing the air abrasion. But in this case, I just went up there and did the air abrasion on the porcelain, I did the air abrasion on the metal, and I did the air abrasion up on the root surface. So this is the Micro-Etcher CD intraoral sandblaster that I was using. Again, just pop off my high-speed handpiece. This has a quick disconnect. I pop that on. I have the abrasive and the little canister on the bottom. And by doing this, we do increase our bond strengths, as been shown by the research. This is my Quick Stat Free Hemostatic gel. So I don't use a ferric-based gel anymore. I use a clear hemostatic gel. Again, this tooth being the anterior, I don't want to make the tissues look dark. And so I just paint some of this up there along the gingiva. I don't even scrub it in. I just use the little stat flow tip. I place it on the gingiva and just rinse it off, and it stops the bleeding. It's my go-to hemostatic agent now, whether it be in the anterior portion of the mouth or the posterior area of the mouth. Now we've got to treat these different surfaces. So on the porcelain portion of this porcelain crown, I place the porcelain etchant from Vista Apex. I place that there for about 60 seconds. I rinse it off thoroughly. Again, it is hydrofluoric acid, so I'm trying not to get on the tissue, and being a gel form or a very viscous form of etchant, it stays where I put it. So I keep it also off the tooth structure, because hydrofluoric acid on tooth structure is like giving your tooth a super fluoride treatment. So we know that if we're going to place fluoride on the tooth, it's going to be harder for us to etch with our phosphoric acid later on. So what I do is I just take this viscous gel of porcelain etchant, I place it on the porcelain, trying to keep it off the soft tissue and the tooth structure. So I'm just going along that little margin, placing it there for 60 seconds, and then rinsing off real thoroughly. And I'll see that porcelain be nice and frosty. So here's the porcelain etchant I use. It's a viscous 9.5% hydrofluoric acid solution. It is really great whenever I'm using Emacs, for example. A lot of the Emacs that we do is we do with our CEREC machine. So I will go ahead and I will clean out the dye material from my CEREC after it's been milled and glazed. Then I will air braid it to get all that material off, and then I'll etch it with this porcelain etchant. Then I'll rinse it out. It rinses out really, really easily. And then I will use the second part of this system, which you see on the top syringe, and that's the silane. Now the silane is going to be a coupling agent between the ceramic of the porcelain and my composite. But I'm going to show you one more item that I could use besides the silane, and it's a very a good material. So now on the tooth itself, I'm going to use Velvet Etch. Velvet Etch is my purple phosphoric acid. I'm going to apply that to that root surface, and again, because it is sclerotic, I'm going to place it for just a little bit longer. So I place it for about 20 seconds, and then I rinse that off. Again, I didn't have this problem, but again, if I had a problem with bleeding, because I'm right up there at the gum, and maybe the air abrasion irritated the tissue, and then when I put my phosphoric acid up there, sometimes that elicits the bleeding, I would use my Quick Stat Free, my clear hemostatic agent. So as I mentioned, my silane can be my cupping agent between my ceramic and my composite that I'm going to repair this crown with. But in this case, what I use is not the silane, but I use ZRP. Now, ZRP is a universal primer that helps us bond metal restorations, porcelain restorations, zirconia restorations to our resin. So what I do is I apply the ZRP primer to the restoration itself, and then air dry that. Do not rinse it off. So in the cervical area, again, where that purple is, that's where I place my Velvet Etch. So the Velvet Etch is my phosphoric acid etchant. It's there for 20 seconds, and I rinse it off thoroughly. Then I use a ZRP, and I place that on my porcelain and my metal, because it will prime both the metal and the porcelain. So I put the ZRP on the metal and the porcelain. So then I air thin that, and we are ready to go. So the Velvet Etch is a purple colored, so it's not your blue. It's a purple colored 40% phosphoric acid etchant. I really like Velvet Etch. It's smooth, it's creamy, it stays where you put it. So if I'm trying to avoid getting it on certain parts of a tooth or on the adjacent teeth, the Velvet Etch just stays right where I place it with this little 22 gauge pre-bent tip. I can place it. It comes off of the tooth very easily. You could take a surgical suction and suction most of it off so the patient doesn't have to taste it while you rinse off the rest. So it's very easy to remove. And so Velvet Etch is just something that's very luxurious. And when you use it, it just looks luxurious. Now the ZRP is a universal primer. It's a universal dental primer, and what you can see on the chart on the bottom is that it will actually increase the bond strengths when you use it. So if you're bonding resin to, let's say, zirconia or alumina or metal surfaces with resin materials, and the resin material could be your cement, you're going to get a better bond. So I really like the versatility of ZRP. So ZRP has many different monomers. And so if I was using the silane would be a good coupling agent between the ceramic, the porcelain, and my composite, but maybe not so good between the metal and my composite. So being able to have a universal primer in this case is advantageous in this treatment. Now what I do is after we've rinsed off the phosphoric acid off of the root surface, we've placed our ZRP and we've dried the ZRP onto the metal and the ceramic surface. Now what I use is Regen Bioactive Adhesive, and I place that both on the tooth, the metal, and the porcelain. It'll be fine being on all three substrates. And then I air thin that. Again, we've talked about this many times, is we use a light stream of air to evaporate out the solvents. And then without the solvents, it's going to get a little thicker, so I use a more vigorous stream of air to really thin it out. And then I come in with my pink wave, quad wave curing light, and I cure that and seal everything up. So I've sealed up the tooth surface, and I've cured my restorative surfaces, both the metal and the ceramic. So again, the Regen Universal Adhesive has a bioactivity because it has Bioglass 4,5-S5 in it, which can generate the regeneration of hydroxyapatite. It has a bioglass, so it helps to create a more alkaline environment so the bacteria doesn't proliferate, and it helps to make that area more resistant to secondary caries. And it's biocompatible. I know a lot of our patients today are concerned, does it have BPA or anything toxic in it? And the Regen Universal Adhesive does not. Now, the pink wave quad curing light is the curing light that has 4 different wavelengths. It has UV, the blue light, the red light, and your infrared. And it has a built-in transilluminator to help us with diagnosing cracks. It has 3 different curing modes, the boost, standard, and the ramp. And it's a very high output light. So in the boost mode, we're at over 1700 milliwatts per centimeter squared. Now, this is a large surface area head, 12.1 millimeter curing area, and it's well collimated so we don't lose that energy. And we have a depth of cure up to 8.5 millimeters. So this curing light is a really heavy duty curing light, and yet it's light and it's very slim. So I can get it back to the 2nd, even 3rd molar areas if I'm trying to put restoration back there and not have to worry about creating shadows in the walls of my preparation. So now that we've got everything prepared on the surface, we're going to use Titan Flowable Composite. Now I'm going to use the white opaque Titan, and that way it'll block out that silver color. And over that, we're going to place an A3 exquisite composite, a sculptable composite. But this composite we're going to warm up, and by warming it up, it's going to soften it up. So the Titan Flowable Composite has been optimized for its handling properties, has very good physical properties. It's radio opaque, so you can see it. And it comes in many different shades, but in this case, because we're blocking out that silver, I'm using the white opaque shade. Now, many of you have heard me say this many times, that when I sculpt my composite, I want to take it to its final shape. I don't want to have to like bulk it up, put a little bit of excess, and then polish it all back down. That's going to be a waste of time. So what I use is I use my composite wetting resin, which is seam-free. So my assistant puts a half a drop of it on the back of my glove, and that's what you see here on the right-hand side is on the back of my glove. She's put about a half a drop, and I put my instrument, my composite shaping instrument, into that, and with a very light coat, not much at all, I can sculpt my composite won't stick, and then we're going to cure that with our pink wave curing light. So seam-free is compatible with all of the methacrylate materials, can be used for indirect and indirect restorations, but it eliminates the tackiness of your composite materials. And so if you've got a really highly filled composite and maybe it's sticky and it sticks to your instrument and you pull your hair out because you're trying to spread it, and instead of spreading, it's curling and being pulled away from the tooth, this is going to be the solution you need to try. It is a resin and it doesn't have any solvents or photoinitiators in it, so it's not going to change the physical properties of your composite. It's not going to make it cure faster, and it's not going to add a layer between layers of composite because it is actually absorbed into the composite that you place it on. So basically, you just put a little bit on your instrument. It's going to help that instrument glide over your composite so you can develop the shape that you want, and then it's going to be absorbed into that composite. And if you place another layer of composite over the top of that, it's not going to add any film thickness that you'll see when you start to polish those layers up. So here you can see I've used my Exquisite, the A3. I've placed it over this area. We haven't polished it up. But you can see I've taken it pretty much to a final shape. All I have to do now is just polish it up a little bit. I just take a composite polishing cup and I go in there and I just polish it up, and we get a really nice shine. So here's the Exquisite Restoration Nanofill Composite. It's a light cured composite, nanofill particles, so you can use it in the anterior, the posterior. Has very nice physical properties, giving you low shrinkage, low abrasion, so it's going to have good wear, and yet it's highly opaque. It comes in syringes or the unit dose compules, and typically I use the unit dose compules just for the cleanliness part of it, the asepsis. Then when I'm using these composite compules, I either use the ThermoFlow composite warmer that's on our bench top. And again, what's been shown is if you warm the composite up, one, it's going to be easier to work with because all that stiffness is going to be gone while it's warmed up. So you can place it on the tooth, sculpt it with your seam free, and very quickly get it to those final contours. So you warm it up, and because it's warmed up, if you're placing it, let's say in a class 2 box, it's going to adapt better to the walls because it's going to be easier to shape up against that area instead of placing something that's really hard and sticky into the tight corners of your prep, so we get better adaptation. And the heating of the composite increases your polymerization, but decreases your polymerization stress. And in doing this, it increases the physical properties of your composite material, so you're doing a lot of good. Another way of warming your composite is using the phaser composite warming gun. So this is using near infrared technology to warm your composite. You can warm that compule up in less than a minute to 150 degrees and begin dispensing it. So when I'm doing it, typically I don't use more than a compule, but if I had to fill a large restoration, I might use 2 or 3 compules. And what I do is as soon as I squeeze out the last part of that compule, my assistant switches that out to the next compule. Now this composite gun's keeping everything warm, so my composite never cools off, which makes it really nice. But when she puts a new compule in there, within 45 seconds, it's going to be warmed up to 150 degrees. So in that 45 seconds, I get in there and I'm sculpting that last layer of composite that I had. I'm sculpting it, I'm shaping it, and by the time I'm done with that, I pick up the gun and the next compule is ready to go. So I really like the phaser because it is your composite delivery gun and your warmer all in one. Because with the benchtop, we have a gun, but when we take the gun out, that composite begins to cool. So my assistants are really good today, they're well trained, that when I'm done with the composite gun, if it's not the phaser, they take the gun from me and they put it back in the warmer so the composite stays warm and soft. So here, now we place the composite. Now we begin to do our polishing to get nice and smooth. And then I'm thinking the reason why this porcelain fractured off was probably because of occlusal forces. So what I then do is I begin to adjust the occlusion, especially on that tooth number 5 or the 1-4. We were hitting a little bit on the lingual incline of the buccal cusp. So I eliminated that because I figured that was putting some flexure on that bridge, and that's why that porcelain fractured off of tooth number 6 or the 1-3. So the occlusion is very important. So the patient was happy. She came in with what you see on the left-hand side, this large porcelain fracture. On the right-hand side is the way that she left. And one thing that I'll point out to you that I probably would do differently in the future is I put that white opaque in that mesial portion a little bit high. And what I would do today, I'm going to just mark it for you. Let me just pull this out. So you can see I covered a lot of this porcelain right in that area. And what you see is there's a little bit of show through in here. And with her lip line, it doesn't make a big difference. And one of the reasons why it shows up with the photography is because the flash is seeing that and kind of getting reflected back through that composite. In normal room light, I didn't see that. And that's one of the things that when I looked at it when I was done, I thought, wow, now everything looks really good. But then when I took a look at the photos afterwards, I could see this little slight demarcation right in here that I could not see in the regular light. But if I had to do something a little bit different, I would just not put my white opaque all the way up here. I would just cover the metal and not cover so much of the porcelain. So that's one thing in hindsight that I would change, but the patient was happy. She made her dinner and she couldn't believe the transition, because when she walked in looking as she did on the far left hand side, she thought for sure we were going to say, oh, you have to remove the bridge, redo the bridge, or she was going to need some implant. And when we told her, no worries, we can go ahead and repair this and get you off to your dinner, she was thrilled by that. So that is the only thing that I would change. She wasn't anything but thrilled. So again, this is just an example when it all comes together, where you can take all the different products, understand how all the different products work, and then take what could be a complex situation or maybe a costly situation for the patients and make it much simpler, and they appreciate it when you can do that. So I hope you like this. I hope you can apply this information. If you liked it, hit the like button. If you want to make sure you don't miss out on more information, hit the subscribe button. And remember, we are forming that community of like-minded clinicians, just like you and I, that want to do the very best for our patients. And so hit subscribe so that we can keep this information coming over to you. And I hope this information helps you, maybe in a case that you're doing today, tomorrow, or upcoming soon. And if you are able to apply this information, just send us a little comment saying that this information helped you out. All right. Anyway, I will see you next week. Take care and thank you very much.